So continuing with the topics related to the gastrointestinal infections, today we'll discuss about the three different kinds of GI tract infections. First of all, let us look at an organism called as Helicobacter pylori. Now please look at the tagline. It says from gastric colonization to carcinogenesis. And I presume that you already know what is meant by carcinogenesis. Means something which is capable of causing carcinoma or malignancy. Now first of all, what is Helicobacter pylori? Obviously it's a bacteria, rather a gram-negative bacteria, and it resides within the stomach. That is known, and that is known by virtue of these two people, Barry Marshall and Robin Warren. You see, previously, patients used to complain of gastritis, reflux, etc. And the main modality of treatment was antacids. And it was presumed it was physiological nature, not an infective cause. The idea of this is not being rather physiological but an infective condition was put forward by these two people. And obviously the medical community initially rejected them. So to prove their theory, they self-ingested the gastric contents of the patient and thereby they themselves got infected. Further research propagated that this organism is the main attributing cause of what is called as gastritis, and down the line it has been implicated as an important cause of stomach CA or malignancy of the stomach. Now if we look at the prevalence of H. pylori in the population, you can see in this world map, almost everywhere in the world, almost everyone is having this organism. Now there lies the question. So whether it is actually implicated for all the disease or it's just a mere theory. Now the International Agency of Research on Cancer, a subsidiary of the World Health Organization, it categorizes the various types of carcinogens, and among the carcinogens, if you look at the group of the classifications, group 1, 2 and 3, based on what is the probability of causing carcinoma in the human body. And among this, H. pylori has been categorized in group 1. That means it is directly implicated to causing gastric adenocarcinoma and MALT lymphoma. MALT lymphoma means mucus-associated lymphatic tissue lymphoma in the stomach. Now, if we look at the pathogenesis, how this infection occurs, initially what happens is the kind of diseases it can cause, it can range from gastric cancer, gastric and duodenal ulcers, adenocarcinoma, MALT lymphoma, and dysplasia/metaplasia. I think you already know about dysplasia and metaplasia by now. Okay. Now there are various mechanisms by which this organism can cause the changes. The important changes include outer membrane proteins that are present on the bacilli. These include the BAB-A, SabA. This organism also produces an enzyme called as urease. That means this enzyme can break down urea. And if it breaks down urea, what happens? It liberates ammonia. And when it dissolves in solution, it turns the solution into basic. That is, the pH is basic. This is one of the reasons why this bacteria is able to survive within the stomach. We do know that the stomach pH is around 2. Most of the microorganisms are killed at this low pH. But Helicobacter can produce urease enzyme, which produces, or rather it degrades the urea to produce ammonia, turning the local mucosal environment basic. And finally, it has some virulence factor like the CagA and VacA. Now let us look at it even more in details. What happens is, with the help of the outer membrane proteins, so coming back to the virulence factors, the first I have already told you, it is the outer membrane proteins. What are outer membrane proteins? These are the proteins which are present outside the cell wall of the bacteria. Now, among these proteins, we have the VacA and the SabA. These actually helps the bacteria to adhere to the gastric mucosa. Now, please remember, if you go back and read about the physiology, the gastric mucosa is slightly different from all other GI intestinal mucosa. Why? Because these cells not only produces acid but also produces a huge amount of mucus layer. This bacteria is able to adhere, it can move through the mucus layer and adhere to these cells. And within these cells, with the production of the urease enzyme, it produces a microenvironment which is basic in nature. So even though the stomach produces acid in a huge number, over here it's a microenvironment which is basic, which allows the bacteria to survive. Furthermore, when the number of the bacilli after the addition, what will happen? The organism will stay there. That is called as colonization, and it will propagate and increase its number in that environment. When the number increases sufficiently, we can find that it causes inflammation in the gastric mucosal cells. That is called as gastritis. How it does? By production of the virulence factor like CagA and VacA. This inflammation results in cell death. Now, when huge number of cells of the mucosal lining dies, we have an open erosion of the mucosa. That is called as an ulcer. If this ulcer is present in the stomach, we call it as gastric ulcer. If it is present on the duodenum, we call it as duodenal ulcer. So these are the factors. Important factors would be, it can negate the acidic challenge of the stomach pH. Next, now this bacteria is motile, has a flagella, and with this it can move through the thick mucus layer of the stomach, thereby leading to adhesions with the help of the outer membrane proteins, and finally with the help of the oncoproteins like cytotoxin associated gene and vacuolating cytotoxin, it produces inflammation. Now, when this inflammation goes on unregulated, this inflammation causes change in the cells of the stomach or the gastric cells, and thereby making the stomach cells dysplastic or metaplastic. Long-standing inflammation can lead to change, we call it as metaplasia. Now, if we look at the diseases it causes, I have already told you it can cause gastritis, that is the inflammation of the gastric mucosa, or we can have what is called as peptic ulcer disease. Peptic ulcer disease means ulcerative disease of the stomach or the duodenum. And finally, we can have malignancies, either gastric acid adenocarcinoma or MALT lymphoma. Not only this bacteria infection in the stomach can also lead to various other manifestations. These systemic manifestations would include iron deficiency anemia and vitamin B12 deficiency. If you already have read about vitamin B12 deficiency and iron deficiency anemia, I think you would be aware about the role of the intrinsic factors which are produced in the stomach. Because of the change of the microenvironment, these factors are also not produced. And finally, many a times, if you have read about the peptic ulcer disease, you will find whenever there is gastritis or supposedly the patient is having duodenal ulcers especially, intake of food relieves the pain. Hence, many a time the patient overeats. And obviously, overeating without physical activity may also lead to metabolic syndrome. Now, look at this picture. So, this is how the progression occurs. This is the normal gastric mucosa. After a human being acquires the H. pylori infection, it leads to chronic active gastritis. Thereafter, that is the phase of gastritis. Thereafter, the cells will die. It is called as gastric atrophy. And then what leads to is called as intestinal metaplasia. That means the cells of the gastric mucosa changes and the cells becomes more like intestinal mucosal cells. And if this prolongs, then we can have dysplasia and finally metaplasia. Now, the gastric ulcer Depending on the depth of the ulcer, it can be superficial ulcer, deep ulcer, and sometimes very deep ulcers. So, what would be the manifestations in case of gastric ulcer? Obviously, pain in the stomach, irritation, pain after eating food. These are the common factors. Sometimes the ulcer bed may invade into the muscularis mucosa and the vessels, eroding the vessels, and it may lead to bleeding in the stomach. That is called as, obviously, if there is bleeding in the stomach, the patient will vomit out the blood. It is called as hematomesis. Fine. Now we have understood what is the organism, what are the kind of disease it causes. Now we have to diagnose the cases. So for diagnosis, we have two types of tests. One is called as invasive test, another the non-invasive test. Now invasive means you are doing a procedure in the body. Now first let us look at the non-invasive test. The non-invasive test include something called as stool antigen test. That is, we look for the antigen of the H. pylori in the stool of the patient. Or we can do what is called as urea breath test. Now do recall, this organism can produce urease, hence it can degrade urea. So the remnants of the ammonia can be found in the breath of these patients. So if we look for the remnants of ammonia in the breath of the patient, it is called as urea breath test. Right now it is a gold standard test for non-invasive diagnosis. Kindly remember this word, it is the gold standard for non-invasive diagnosis. Although it's not confirmatory, but it's a non-invasive test. And finally, we can also do the culture of the stool or serology from urine or saliva. Coming to the invasive test, what are the invasive tests we can do? The most important invasive procedure that we can do is called as endoscopy. So if we put an endoscope through the mouth into the stomach, we can reach where the erosion is on the stomach lining. And from there we can take a biopsy sample and directly look at the change of the mucosa. Thereby we can categorize at what stage the disease is, whether the change is only inflammatory change or dysplastic change or metaplastic change. So that is the histopathology. Now, so histopathology is the gold standard for assessing the mucosal damage. But remember, it's an invasive test. The next what we can do is something called as rapid urease test. Now this is different from urea breath test. So what happens over here, it provides quick results on the pH change. What is done? We take some tissue sample directly from the ulcer bed or the mucosal eroded area and then test those cells for rapid urea. So when we do the endoscopy, we can take out the little bit of tissue sample, directly process it for the rapid urease test, and then send for histopathology. And the last thing that we can do from the tissue sample, we can put the tissue sample for culture so as to isolate the organism and then test for the antimicrobial susceptibility test. This will give us the indication of the kind of the antibiotics which could be given to the patient. Okay. So these are the tests, non-invasive test and the invasive test. Currently, because the cultures are difficult to obtain and furthermore invasive test is done, we can also take the tissue samples and directly test with the molecular method, that is the nucleic amplification test or fluorescence in situ hybridization test. These are the molecular tests which gives much faster or rapid results. Now this is the flowchart of the evolution of this pathology over the years. The organism was identified a lot earlier, but it was implicated late in the 2000s, and then the therapy was designed, first the triple therapy, then quadruple therapy, and now the dual therapy is recommended. Now let us look at the type of the therapy that can be given. The first is the triple therapy. Triple therapy means we include a PPI or a proton pump inhibitor like an omeprazole or pantoprazole, etc., along with antibiotics of the class clarithromycin or amoxicillin, and give the patient for 7 days. This therapy is given after confirming the diagnosis. Either we can confirm with a non-invasive test like the urea breath test, or after confirming with invasive test. Other therapy that we can give is the bismuth therapy. Now please remember, in all this therapy, something is common, that is the PPIs. These PPIs are a very important part of the therapy, and that would be, I think, discussed in your pharmacology classes. Finally, efforts are being made to produce a vaccine, and initially it was thought that if we can eradicate this bacteria from everyone, we can prevent the occurrence of gastric carcinoma. Thereafter, it was found that this is not the sole cause of gastric carcinoma. There are many other causes which leads to gastric carcinoma. But Helicobacter pylori has some beneficial effects also. It has been seen that the presence of this bacterium in the stomach, especially during the growth phase of a child from 2 to 12 years, it modulates the immune response of the human body to the environment. What it does is, it teaches the human body to react to external pathogens, so that the body does not react to each and every antigen that the human body faces. So Helicobacter pylori is not only a bad bacteria, but it also has some beneficial effects. Okay. Now please answer these questions. Which of the following is considered the gold standard non-invasive diagnostic test for H. pylori? So every bacteria has some kind of secretion system by which it can produce some metabolic products. It could be an enzyme, it could be a protein, and it can give out this product into the environment. And this system is called as the secretory system. There are 4 types of secretory system, and this is the type 4 secretory system. Okay. Now, H. pylori is a unique pathogen because of its ability to survive in a highly acidic gastric environment, which is the primary mechanism by which it neutralizes the stomach acid. It is the urease production. Biofilm formation can protect for some time, but main thing is that because of the production of urease, it neutralizes the gastric acid. Okay. Now let us look at another bacteria. This bacteria is called as Campylobacter. So initially this bacteria was not very much attributed to cause human disease, and it was thought it is mainly a zoonotic in nature. Zoonotic means some diseases which are acquired from animals to the human beings. So this was commonly seen in people who used to handle poultry, that means chickens, ducks, etc., and involved in business of eggs. However, thereafter we can see that this infection is pretty much very common everywhere. And one of the important factors which make this infection very common is a very low infective dose. What is infective dose? It is the number of the organism that is required for a person to get infected. Now this is a fecal-oral transmission, that means the organisms are obtained during eating with food and water. Now if you look at the world map, we can find that Campylobacter is common everywhere in the world. Initially, it was reported more commonly in the Western Hemisphere, but now with advanced diagnosis, we can find Campylobacter is very much common or pretty much all over the world. Now, this bacteria has many species which can cause similar type of illness. The most important species is Campylobacter jejuni. And what this bacteria is, it's a gram-negative slender curved-shaped bacteria. And if we look at the gram stain, you can find some of the morphological finding over here is some bacteria lies like this, a V-shaped or S-shaped bacteria. Hence, it was called as gull-wing appearance. Gull means there is a bird which, when it opens its wings, it almost looks like this. Hence, it is also called as gull-wing bacilli. Now, this organism has a single flagella by which it demonstrates motility, which also resembles corkscrew motility. And a very important part is that this bacteria, the growth requirements are different from other common bacteria which causes human disease, which is it is microaerophilic. Remember the term microaerophilic. Aero means oxygen. When we say an organism is aerobic, that means it requires oxygen. So normally when we say aerobic, that means we are talking about the percentage of oxygen that is present in the room air. That is about 20 to 21%. But this organism is microaerophilic. That means it needs oxygen. But at 20 to 21% of oxygen, it cannot survive. It will survive and grow at a percentage of 5 to 10% of oxygen. Hence, it is called as microaerophilic. The second important part is that this organism grows at a temperature of about 42 degrees centigrade, not at 37 degrees centigrade. Remember, the birds, they have a higher body temperature as compared to human beings. So this is basically a pathogen of the birds. Okay. Now this is the list of all Campylobacter species which causes human disease. But as far as you're concerned, most important species would be Campylobacter jejuni and Campylobacter coli. Now remember, jejuni is the most important cause of human infections. And there is one more organism, that is the Campylobacter fetus. It causes bacteremia and severe infections, especially in immunocompromised patients. Okay, now how does this infection is acquired? So commonly what was thought, it was acquired from ingestion of poultry products which may not have been cleaned or sterilized properly. It could be eggs, it could be chicken, etc. And from there, on consumption, it enters to the oral route. Also, it can be begetted from another person who is already infected. That is, there is person to person transmission. Okay, that is what I am saying. Initially, it was thought that it is only fecal-oral. Although the predominant mode of acquiring infection is fecal-oral, but person to person transmission also occurs. Now, what are the manifestations? These are the whole list of manifestations. If you go through that, it can infect anywhere in the body, from causing CNS infections like meningitis, brain abscess, dental infections, systemic infections like bacteremia, endocarditis, hepatitis, intestinal infections like gastritis, gastroenteritis, and if you look over here, something called as reactive arthritis. Now, how does reactive arthritis occur? Because it can trigger the immune response of the human body, producing various antibodies against the organisms, this organism, and this antibody will act on various parts of the human body, causing autoimmune diseases. Okay. Now, this is how the infection occurs. Initially, obviously, the modality is same. That is, after acquiring, it will adhere to the intestinal mucosa, then colonize, and then produce various kinds of toxins which leads to cell death. And when this organism is expressed to the human immune system, it will produce antibodies. Now, these antibodies may have an autoimmune effect. And a very notable effect that is seen in the aftermath of the GI infection is called as GB syndrome or Guillain-Barré syndrome. I'll come to it later. Okay. Now coming to the clinical presentation, incubation period is about 1 week. Initially, there is a program of about 1 to 3 days with predominantly GI manifestation, including gastroenteritis and fever. Thereafter, the presentation could include or be like enteritis. That is, it is characterized by voluminous diarrhea, huge volume diarrhea, which may be bloody with severe abdominal cramping and the frequent stools, as much as 10 stools per day. That is the acute enteritis phase. Sometimes it may also be causing what is called as acute abdomen. That is, it may mimic appendicitis. Now, to detect this organism, obviously we can go for stool culture or molecular methods. And obviously, culture is more difficult because I've already said it is a microaerophilic organism and requires a different temperature. Molecular methods and enzyme immunoassays are much better in diagnosis this organism. Now, after the acute phase, that is, after the gastroenteritis phase is over, the antibodies that are produced against this organism may affect various parts of the body. The first thing that we can see, or the most common thing that we can see, is called as the Guillain-Barré syndrome, where there is molecular mimicry in which the immune system produces antibody against the Campylobacter, and this antibody attacks the peripheral nerve myelin. That is, the myelin sheaths of the peripheral nerves. So the patient may present with a history of ascending paralysis. Okay. So this is very common, GBS syndrome, and treatment, obviously the mainstay of the treatment will be IVIGs and plasmapheresis. Other autoimmune manifestation that is seen is called as reactive arthritis. In the same way, the antibodies which are produced will act on the synovial tissue of the joints, leading to arthritis. Sometimes rare events like bacteremia, myocarditis, and toxic megacolon can also be seen. Now, how to approach this patient? First thing first, if the patient is presenting with features of enteritis, we'll treat the patient like that of, I've already told you, like that in case of a diarrhea management, based on the status of hydration. However, if the patient gives a history of acute fever, pain abdomen, severe pain abdomen, or bloody diarrhea, we can have to give antibiotics. Furthermore, antibiotics should be initiated early in elderly patients and patients which are immune compromised. The main drug of choice is macrolides. Earlier, fluoroquinolones were used frequently, but now resistance to fluoroquinolones have been noted, hence azithromycin is advocated for this organism. Now coming to the multiple choice questions, please answer this question. A patient presents with a bloody diarrhea and severe right quadrant pain mimicking appendicitis after consume undercooked chicken. What is the minimum infectious dose? Which complication of the Campylobacter infection is characterized by symmetrical ascending paralysis? It is called as a Guillain-Barré or GBS syndrome. Okay. Which antibiotic therapy is warranted for severe Campylobacter infection? Macrolides. Now please remember, if GBS has already set in, there may be no role of the antibiotics. Okay. Because most of the time, the infection, acute enteritic infection is already over. Okay. Coming to the last organism that we are going to discuss today, this organism has undergone a name change recently. So in your books, you may find this organism labeled as Clostridium difficile, but now it has been renamed as Clostriditis difficile. Now I think you have read about Clostridium, it's an anaerobic bacteria. Now, Clostriditis is also an anaerobic bacteria, and it is associated with what is called as antibiotic-associated colitis. Now let me go and explain what is this organism and what are the diseases it causes. Now first things first, it's a gram-positive, obligate anaerobic, spore-forming bacilli. These are the three very important. First is gram-positive. Okay, that means it has got a thicker cell wall. First point. Second point, it's an obligate anaerobe. Obligate anaerobe means it cannot survive even mere exposure to oxygen at room air. And finally, it is a spore-forming bacilli. So in order to survive in the environment, it must form spore. So that is the mode by which this organism can survive. Now, which part of the human body resides most of the anaerobic organism? It's the gut. So if a person ingests the spore of this bacilli from the environment, what will happen? This spore will enter into the GI tract, especially the intestines, and in that anaerobic environment, it will proliferate and grow. Have you understood this? So this is how the infection is acquired. But please remember, mere acquiring the organism does not lead to the disease. Why? Because in case of a normal human being, the gut mucosa has more number of the resident microbial flora, huge number of bacteria. These bacteria normally would not allow this Clostriditis to grow. So suppose if we ingest some spores of C. difficile, nothing will happen. But take a person in whom there is gut microbial dysbiosis. That means the normal flora of the gut is altered. So if that is altered, the normal microbiome will allow, because it is not present, this bacteria will be allowed to grow and proliferate. Okay. Now coming to these spores, they are very hardy spores and they can survive in the environment for a prolonged period of time, and they can also survive many chemical agents which are frequently used in the hospitals and laboratories. Commonly we have a perception that if we use a hand rub, that is alcohol based hand rub, most of the organisms die. But always remember, the spores of these bacilli have no effect of alcohol. So to get rid of the spores of these bacilli, you have to use soap and water. Okay? So how does the disease progresses? The C. difficile infection, CDI means C. difficile infection, it can range from asymptomatic carriage, that means the organism is merely present in the gut and is expelled along with the fecal matter of the patient, or mild infection may lead to mild diarrhea, and sometimes if there is severe propagation of this bacteria and production of toxin, we can find something called as pseudomembranous colitis, toxic megacolon, and finally septic shock. Septic shock means, what is shock? Okay. So the patient will present with various manifestations like watery diarrhea, sometimes even bloody diarrhea, persistent abdominal pain, abdominal swelling, distension, nausea, vomiting, loss of appetite, fever, and rapid heart rate. So these are very common symptoms, but always keep in mind of these symptoms if a patient presents who has undertaken broad spectrum antibiotics for a sufficient period of time. So this is how this infection occurs. The infection is acquired either from the community or from the hospital or environment, mainly through food and water. After the spores is ingested, this spore enter into the gut. Because the spores are highly resilient, the stomach acidity has almost no effect on them. It reaches the intestine, colonizes there, and inside the colon it produces two types of toxins, toxins A and toxin B. The cell death in the intestinal mucosa results directly from the production of these toxins. Now, because of these toxins, there is cell death, and sometimes the inflammation can also erode the blood vessels, leading to diarrhea. And sometimes these organisms may enter into the blood vessels, causing sepsis. One more thing that you must understand, because of the inflammation, severe amount of cytokines are released in the intestinal mucosa, leading to accumulation of mucus and inflammatory cells. And there is almost like a membranous covering of the mucosal membrane. This is not a membrane. This is only an inflammatory exudate. Hence, it is called as pseudomembrane. And along with it, because there is inflammation of the colon, it is called as pseudomembranous colitis. Now, there is obviously this bacteria has many strains. One very important strain is NAP1 BI027. Now, this is of epidemic concern. Epidemic concern means it can spread rapidly from one place to the other and cause outbreak. And this is very important because it can produce high level of toxins. That means it can produce high levels of toxin, hence the propensity to cause pseudomembranous colitis, toxic septic shock is more high. Furthermore, this strain is also resistant to quinolone. So hence it is very difficult to treat also. Okay. Now let us look at the risk factors. Which of the patient population are at risk of C. difficile infection? The most important factor is recent antibiotic exposure. I'll come to the group of the antibiotics. Next, advanced age. Why advanced age? Because with the age, not only the body's immune system gives up, but also the microbial flora also changes. Next, proton pump inhibitors. I've already told you the spores are resistant to acid, but if a patient is already taking PPIs for a prolonged period of time, so whatever chances of the spores were there for degradation in the acidic environment of the stomach is already gone. So patients who are on PPI for prolonged period of time have a higher propensity of getting this infection. Now if you generally ask many patients around yourself, you will find there are many people who are taking PPI like pantoprazole or omeprazole for a prolonged period of time, 2 months, 3 months continuously. So that is a very, very bad habit. Next comes the prolonged hospital stay. Why? If a patient is staying in the hospital for a prolonged period of time, that means the patient obviously has got some kind of antibiotic therapy for a prolonged period of time. Furthermore, the higher probability of the patient getting exposed to spores of this bacillus. And finally, immune suppression is a very important risk factor. Now, this was what was thought earlier. Nowadays, there is something called as changing trends. What changes that we are observing right now? Earlier, it was presumed that this infection was more common in patients who are immune compromised or elderly, etc. and etc. But today's we can see something called as community acquired CDI. Young, healthy people, they are also getting infected. So keep these risk factors in mind, but also keep in mind that mere absence of this risk factor does not exclude anybody from having this infection. Moving on, I've already told you antibiotic exposure is a very, very significant risk factor. What kind of antibiotics? So this is the categorization of antibiotics. You can see the antibiotics have been classified into low, medium and high. That means antibiotics like imipenem, meropenem, if it is given, there is a higher probability of getting C. difficile infection. So whenever a patient is getting antibiotics of say high or medium risk antibiotics, please keep in mind that C. difficile infection can occur. And if this patient suddenly presents with watery diarrhea, pain abdomen, vomiting, etc., keep in mind that C. difficile infection may be present. Okay. So the clinical presentation may be, I've already told you, common clinical features like fever with diarrhea along with dysbiosis, then pseudomembranous colitis because of the inflammatory exudate, or it can lead to fulminant colitis. Fulminant colitis is a stage in which the blood supply of the mucous membrane and the colon is disrupted. And sepsis. If the organism enters into the bloodstream, it can also cause sepsis. So these are the various clinical manifestations of C. difficile infection. Now let us come to diagnosis. How can we diagnose this case? First things first, testing is not recommended for asymptomatic carriers. So the patient must be should have symptom, either diarrhea or features of pseudomembranous colitis, etc. Now the testing is a two-step algorithm. That means there must be a screening test and a confirmatory test. The first screening test that it can be done is something called as GDH or glutamate dehydrogenase. So this is a C. difficile antigen. If it is present in the stool of the patient, that means the patient could probably be infected. That is the first step. Or we can test with a molecular test, that is the nucleic acid amplification test, to detect the presence of this bacteria in the stool of the patient. But also remember If the spores are present in the stool, this test will come positive. So just mere presence of the bacteria in the intestine does not mean the patient is having the colitis due to C. difficile. Confirmatory test means we have to confirm whether the toxins are being produced in the gut or not, because the main mode of disease is production of toxins. These toxins can be detected with the help of enzyme immunoassay. Understood? So for screening test, we can either detect the antigen or the DNA of the bacteria. Now please remember, the antigen and DNA are also present not only in viable bacteria but also in the spore. Furthermore, it may or may not produce the disease. Hence, it is called as a screening test. But to confirm, we need to establish that the disease is occurring. That means the bacteria is actually producing the toxin. So for confirmation, we must detect the toxin A and B with the help of enzyme immunoassays. Have you understood? Okay. Now also remember, before proceeding to the confirmatory test, the screening test must be positive. If the screening test is negative, there is no point of doing the confirmatory test. Okay. Other investigation that can be helpful includes the imaging studies like a CT scan of the abdomen. And we can also do what is called as colonoscopy. That is, we can put an endoscope through the anal canal and reach to the colon and look there locally. Now, for example, in this picture you can see inside the colon there are numerous areas. Can you appreciate yellowish color? And there it looks as if like a growth or a membrane-like structure which is yellowish in color. So this is how endoscopic appearance is seen. Okay. So now we have explained what is the organism, what is the disease it causes, how can we confirm the diagnosis. The next very important step is what to do. So there are two main important factors that you must undertake or understand in managing this case. First is, obviously you have to treat the patient, and second very important part is you should take some precautions so that this infection does not spread to another patient who is also present in the hospital. That means this disease should not spread, otherwise it will lead to an outbreak. So coming to the treatment of the case, obviously because it's a bacteria, we need to give antibiotics. The antibiotics, first line antibiotics is fidaxomine, about 200 milligrams twice daily for 10 days, or we can give oral vancomycin. Not systemic vancomycin, but oral vancomycin. The second line therapy is metronidazole. It is now reserved for the second line or resistant cases. Some of the monoclonal antibodies have also been tested for diagnosis, especially in case of resistant and recurrent cases. And finally, in many patients, especially the recurrent cases, we can also undertake what is called as fecal microbiota transplantation. In case of severe infections, including toxic megacolon and gross destruction of the intestine, surgical intervention with resection of the intestinal part can also be done. So this is the modality of the treatment. Okay. So what are the modalities? The medical therapy, treatment of the recurrent cases, and surgical therapy. Obviously the surgical cases, especially for where the intestinal destruction is there. First line therapy would include fidaxomine or oral vancomycin. In case of recurrent cases, we can give for, or resistant cases, we can go for metronidazole or monoclonal antibiotic like basilitoxumab, or we can go for fecal microbiota transplantation. Now, that was all about treating the patient. Now, how to prevent this infection from spreading? We need to do what is called as the infection prevention and control measures, or IPC measures. The first things first is you have to isolation. You have to isolate the patient from other patients. Okay. Till the diagnosis is confirmed, patients can be cohorted. That means people with GI disorders can be cohorted. But after confirmation, this patient has to be given a separate room with a separate toilet. Now, presumptively, we can isolate the patient if the patient has stool incontinence. Remember, the spores are excluded through the stool. So, if the patient on antibiotics or long-term hospitalization suddenly develops diarrhea, that patient must be isolated. That is the first step. The second step that we have to do is all the healthcare workers, including the doctors, nurses, the technicians, even the cleaners who take up the biomedical waste, they have to use gloves and gowns whenever they enter a room with a patient of CDI infection. Because the whole environment is contaminated with the spores of C. difficile bacteria. And all the equipment that are used on those patients must be single use. That means they are not to be reused, or those equipment should be treated with sporicidal agents. Now, from how long do we need to take these precautions? These precautions should be taken at least 48 hours after the patient's diarrhea has resolved. Okay? So, from onset of diarrhea, 48 hours till the diarrhea has resolved. Next, hand hygiene is very important. I have already told you, the spores are resistant to alcohol. So, any alcohol-based hand rub would not work in this case scenario. What you need to use is soap and water. So, all the moments of hand hygiene has to be performed along with soap and water. And furthermore, all the equipments, etc., which are used on this patient has to be treated with sporicidal agents, because most of the bacteria are present in the spore formation. Now, coming to the cleaning, you have isolated the patient. The patient outcome may be two ways. Either the patient may die because of the disease, or the patient may recover. In any case, when the patient vacates the room, we need to do a cleaning that is called as terminal cleaning. And as long as the patient is there in that isolation room, daily cleaning has to be done. So whatever may be the cleaning, the daily cleaning or terminal cleaning, in these CDI infections, only sporicidal agents has to be used. Okay. Next, a very important role is antibiotic stewardship program. Incoherent, unjudicious use of antibiotics will further propagate the problem. So, every hospital institute should have its own antibiotic stewardship program so as to use antibiotics judicially and according to local epidemiology, so that the chances of spreading of C. difficile infection can be reduced. So, to summarize all the practices that we can do is, what are the core practices? How the disease can spread from the spores? By contact precaution. So, we need to do contact precaution during the period of diarrhea, that is 48 hours till the diarrhea is resolved. Hand hygiene with soap and water, cleaning and disinfection with sporicidal agents. All the laboratories has to be informed earlier that this could be a patient suspected of CDI infection. Otherwise, the infection may spread even into the laboratories. Then, all the healthcare personnel, from doctors to nurses to housekeeping people, have to be educated about handling a patient of CDI infection. Antibiotic stewardship and surveillance should be there. Now, coming to the questions. What is the primary molecular mechanism by which C. difficile toxins cause colonization damage? It is now, most diagnostic guidelines CDI recommend two-step algorithm. If the patient's initial screening for GDH or glutamate dehydrogenase or NAT is positive, what would be the confirmatory test or the next test? Yes, we should look for toxin A and B through enzyme assay. Next, according to the current evidence-based guidelines, which of the following is now preferred? First line antibiotic for initial treatment or fidaxomicin, oral fidaxomicin is the next. The second choice would be oral vancomycin. Okay. Any questions? So today we have covered 3 infections. H. pylori, which affects the stomach. It can cause from gastritis to stomach carcinoma. Then we discussed about Campylobacter jejuni, which predominantly causes diarrhea, but as a sequelae can cause autoimmune diseases which can range from GB syndrome to reactive arthritis. And finally, we had discussed about Clostriditis difficile infection. It is also called as antibiotic-associated diarrhea, and how to approach these cases and treat this patient. Okay.